actually. And by this, we expect the normal exchange of the dentition. Okay, but rarely it occurs. It is always that environmental factors works, and there is a differences in the myoforces. That is, one side it is tongue, one side it is lip, and on the sidewise it is a buccinator muscle. So the ratio or the proper alignment of the myoforces around your neutral zone is always differ. So it is this is a very ideal situation, but rarely we encounter this in the clinic. So this is a survey done in the 1988 in the Japan, that from three at the 3 years, this is 11.4% of the malocclusion is there, and which remain static up to 6. But as soon as the exchange of dentition is taking place, it increases to the 3-folds. So that environmental factors and the exchange mechanism, that recognizing your dentition, primary dentition, and how it is happening during the exchange. What are the environmental factors are playing role onto the tooth, and what is the size of teeth, and what is the size of your space, okay, in the arch, that matters, and can we solve it? So that is my lecture. You will listen this lecture first, you understand the importance of the spaces present in the primary and the mixed dentition, and then you will be able to do the you will be more familiar for the, and you will learn the need of your diagnostics. Okay, and you will be able to use my app more easily. So this is a correlation of size between the primary and subcutaneous tooth. Apart from the environmental factors, there are some dental factors that you cannot change. This is correlation between the primary and it is a B. Only some cases are there. 1/3 of the cases have in the population had equal, they have a good correlation between primary teeth size and the permanent teeth size, that they will not be in the crowded state. But in some it was smaller, and while in the other it was bigger. So if it is a bigger, it is always a severe arches, severe crowding arches. And the recent researches also proves this, that the tooth widths and arch length in primary early mixed dentition and permanent class 1 normal dentition to class 1 and class 2 crowded dentition. The result is the crowded dentition group had a significantly greater mean sum of the tooth widths than the class 1 normal group. In both the genders, crowded dentition had significantly greater mean sum of the tooth width than class 1 normal for both maxilla and mandible in mixed dentition and the permanent dentition. So therefore, there is always a discrepancy of people who are myologists or who are new. They say that teeth size are normal, but arch space or the available space is smaller because of the habits or because of the um, changed masticatory efficiency. But it is not true in all the cases, although the maximum cases may have, but there are cases where you cannot see. Then this is about the space available and space required. The previous report that considered the arch length, arch circumference, and the tooth dimension. Now there is one more report is there. This is which compared crowded group, that is CG, to the non-crowded group, and the criteria were And then the result is the total width of the 4 mandibular incisor did not differ significantly between crowded group or the non-crowded group. So little different opinion. The significant inverse correlation were found between crowding and available space. That means available space and crowding. If the available space is less, always a crowding will be there. Deciduous intercanine width, that is a new finding, and deciduous intermolar width. The permanent intermolar width and the interalveolar width. The total incisor width was directly correlated with the crowding. So this report says if the intercanine width and deciduous intermolar width are deficient, definitely there will be crowding. And I can say there definitely there are some environmental phases acting on the arch, maybe habit, or maybe some masticatory habit, maybe oral habits like mouth breathing or thumb sucking, etc., which is acting to decrease the intercanine width. So these are all are the indicators like arch circumference, the tooth material, the transverse dimension, the measurements in the transfer dimension are the important indicators of your arch type, whether it will be a non-crowded arch, whether it is a borderline arch, or whether it is a severe arch. That eruption pattern is different in all the arches. So these are the important indicators that you can predict what will be the status of crowding in future, and you can start your treatment immediately whenever you are seeing, and you should lay down your treatment plan accordingly. So they suggested individual variation play important role in the treatment planning. However, one must not overlook the arch length discrepancies and transverse arch length discrepancies together with the transverse discrepancies in the patient with mandibular anterior crowding, because they have studied mandibular anterior crowding, and which you see as a first sign of the crowding. Okay. But in the coming slides, I will show you it is not always arch length discrepancies and it is not always transfer discrepancies, but that is a mandibular relation also. Okay, so however, whatever is there, but these indicators should be considered in laying down your treatment plan. So this is a width they have taken. This is, sorry. This is little wrong. Intercanine width is not the first molar width. First deciduous molar width is equivalent to your measured premolar width, measured premolar value. While the 4 number is measured molar value, which has been given by Ponds and the Schwartz as well. So these are the important indicators, and these are given in my app, Ortho Assistant app. So you should see, or always see, and that is for deciduous also, and that is for permanent tooth also. Okay. For both, the values are given, and for both Ponds and Schwartz, normal values are given by different studies, and by this you can lay down whether the arch is collapsed, the arch has a narrow, or whether arch is normal. Am I audible, Dr. Akanksha?
Yes, ma'am. Yes, ma'am. You're audible, ma'am.
Okay.
Yes, ma'am, you are audible.
Very clear.
Okay, okay.
You are very clear, ma'am.
So everybody was so silent. So I thought, okay. So many times you see these type of the patient come. This is very clear. This is a dolichocephalic face, expected to have a narrow arch and with good amount of tooth material. But here you see there is a decreased arch width, very deep palate, low tongue. So that everything is adding the deficient arch space. So the treatment according to your indicators, that if a patient has a deficient measured deficient MPV or the MMV, you will have to expand this arch. Okay, and if it is narrow, you can go with the some other serial extraction type. Okay, so although it is looking like it is severely crowding and a patient probably have a deficient arch, but after the calculation, it may result something else. But in early dentition, expansion plus extraction or expansion plus space supervision can be a treatment plan. So, and also we do have patients like this. In the mandible, it seems it is crowded. And here the space maintainer is given and the developing malocclusion is not considered before giving this space maintainer. Okay, and there is some caries because of the this contact, tight contacts, both the side, canine. Okay, and here it is more than 4 millimeter of the mandibular anterior crowding is there. And this is space maintenance because we are not tamed, we are not trained to look the developing incisor crowding. When the patient has the primary complaint, then only we look at this. Similarly, the endodontics and space maintainer are nicely given, although the design, traditional design is maintaining the space for premolar, but it is not, the doctor is not treating this crowding. Okay, so this is insufficient or insufficient pediatric dentistry. We should look after this also. Here also the good endodontics is done, and you can see the patient is going to a good, very reputed, patient is also very financially good. Patient received the zirconia crown, but you can see the developing crowding in the mandible. So what is the reason? Here it may be something else, and while here it is something else. Look after the maxillomandibular relation. You see little bit of crowding is there. That may be because of the habit, or that may be because of some incisor space discrepancy. Whatever may be the reason, but the developing crowding is because of this maxillary central incisor, which is little retroclined. Okay, so that is why there is a developing crowding in the mandible. Does it, many argue and many have a discussion that mandibular crowding relieve itself a little bit of, does it relieve? You see the angulation did not change. This is a little bit prognathic, this is retrognathic still, and you can see the midline shift. You can see the midline shift, and here space left is very less for the eruption of canine both sides. This is lingually placed. This side it is a collapsed arch, and you can see the erupting canine, ectopic erupting canine, because at the time of incisor exchange, the space is not taken into the consideration because we did not measure the space, the incisor liability. We did not measure the buccal space discrepancy, and we did not see the maxillomandibular relation. Okay, so these are the things we should know, and we should see the asymmetries lies in it, and we should document and we should relieve this. That is our duty. Very easy. What will you do now? The only thing left is the mechanical orthodontics. Okay, and just it is the ignorance, that is the negligence. Simple. Apart from this, you can see this premolar has erupted. If the space considerations were given, and if you have a ready with your values, incisor liability and the buccal is, that means leeway space calculation you would have started the space supervision in this. This is a class 1 case, or the flush terminal place and on case, you would have gone for the many types of the treatment plan I will be telling further. But these are the some negligent cases which where the pediatric dentist did not see the developing malocclusion. Very often we are more prone for endodontics or prevention. Even the fluorides वगैरह हम लोग पढ़ते तो बहुत हैं लेकिन देते बहुत कम है. And then you see this case early. Okay, there are many cases and these are the negligent cases. You can see ectopic canine in this case, both side, and here same side there are the ectopic canines. Now can you correlate? There must be something common. Why the canine is ectopic? Always. You can see the collapse of arch on this side. And you can see the midline shift even in the maxilla, and greater to the greater amount, it is midline shift is there in the mandible. So here is the collapse of arch. Patient is, that is why there is a ectopic canine in both the side, both the teeth. You can see the collapse of arch. So there is a difference when we have a, but it is very rare. There is no space of loss in spite of the caries. 6 is erupted or erupting, but there is no space loss. You can see the D. It is the long axis of the erupting tooth and the deciduous, it is in the alignment. There is no deflection of the erupting pathway. Okay. So this patient must probably has the open space type of the deciduous teeth, deciduous arch, and the incisor exchange is very smooth. So there is no space loss in spite of the distal caries. There is no space loss from while eruption of the 6, and there is no space loss from the anterior side also. But you can see the crowded, when there are the crowded arches, you find the altered eruption pathway, both sides. Okay, this is the carious T and there is a space loss, both sides. Here and in the mandible, the all three X-rays are belong to the one patient only, and you can see the space loss in all the arches. So what are these factors? What are these factors that is contributing to the space loss in one case while it is not in the other case? So there are some eruptive forces acting while the eruption of the permanent teeth from the incisor exchange anteriorly and from the developing erupting 6 in the posterior region. So this is a sandwich tooth. So there are chances of space loss from anterior and from the posterior also. And you can see many signs of the severe crowding, resorption of the lateral incisal while resorption of the canine root while eruption of the premolar. Here, resorption of the canine due to the eruption of this canine early, it is erupting early. Okay. The resorption of the root is a sign of severity of the crowding in the bone only, in the alveolus only. So this probably is a heavily crowded arch. By seeing these radiographs, you can predict the future. You can predict the crowding. Students comes to me with for the specimen whether to extract or whether to go for the pulpectomies. And what would you? I always say go and see the status of the mandible incisors. It must be crowded, and it is often. It is therefore most important to carefully monitor the occlusal development of children at an early age in order to reduce the degree of severity of the crowding of any malocclusion as such. Fortunately, the emphasis in dentistry for the children is clearly shifting. My lecture and the rest of the lecture are the proof of that. The Madam Shobha ma'am has invited many of the speakers who have an orthodontic inclination here. So the children is that it is clearly shifting towards an increased awareness of the prevention, not only of the dental caries, but also in preventing the disharmony of oral functions as a result of malocclusion. So the primary dentition, it lasts from 2 to 6 years. Only caries is there, or some of the oral habits are there, which are reverse. The whatever effects are there, it is reversible. But it may happen to functional mandibular shift are there, prediction of future crowding we do, space maintenance, space supervision, and passive guidance we do give. While in the mixed dentition, where the threefold increase of the malocclusion may occur if it is not taken care. Okay, so here also you have everything, but the environmental forces act very rapidly. If the caries is there, early exfoliations are there, oral habits are there, jaw growth may be may change the pattern if the any of the above three factors are there. Jaw growth itself is a very active during this. So whatever, if the environmental factors are acting, so jaw growth will 100% will be directed in a abnormal way that may cause a very serious sequences. Incisor liability, that means incisor exchange is there, so we should take care of the incisor liability and the leeway space. Secondary spacing is occurring, we should take care of that. Muscular influences are changed according to class 1, class 2, or whether it is class 3. So all different muscles will act on the arches and or act on the a bone. And same thing, we should consider functional mandibular shift, and we should start space supervision with guidance of eruption, be it non-extraction or the extraction approach. And here we should go for the active guidance. In the permanent dentition, that is 12 years onwards, resolution of crowding should be there, and we should start with the retention phase. First, start with what are the normal existing spaces in the deciduous arches, primary arches. That is a 5-year-old patient where the 6 is in the process of eruption. Okay. And here is in mandible, it is distal to the D, while in maxilla, it is mesial to the D. When this primate space is utilized for the incisor exchange for the incisors, while here in the buccal space, that is for the 3, 4, 5. Okay, or for the eruption, with the eruption of 6, the space usually closes. The importance is very the importance of primate space is very much for the space supervision cases. I will be explaining later in the further slides. The important thing is the spaces are closed by the eruptive forces of the lower first premolar. So the eruptive forces are so important. You know that 6 is causing pressure on the E, and then from the E it is transferred to the D, and both of the teeth are moving forward and it is closed, you know. So how much is the eruptive pressure? So I suggest all of you, if you are very familiar with the erupting pattern, you can use this force in the day-to-day basis. Let us know little more about the deciduous arches. You encounter these type of the arches which has a physiologic space as well as the primate spaces, and spacing is 3 to 6 millimeter. It is expected there will not be any transitional crowding. Okay. Another thing I want to emphasize that the intercuspation of this C is very important in any of the arches. Okay, remember this, intercuspation is very important. Okay, so that results in a good arrangement of the erupting incisors. Here you can see there is a large overjet and there is no intercuspation, and it is lingually placed. So the mandible is also very behind, and it may go to the class 2 case because of the muscle forces acting on this lower vestibule. Also, together with the spacing is less than 3. Physiologic spaces are not there, only primate spaces existing. You can expect 20%, in the 20% of the cases, incisor crowding may occur. And if the tooth size, primary tooth size and the permanent tooth size matches, then there will not be any crowding. But by chance, if the permanent tooth size is bigger, 100% there will be the crowding. Then comes the non-spaced arch, where no spaces are present. You can see the 50% of incisor crowding. Okay. And there are some cases in which incisors are already crowded. Here, 100% incisor crowding will be there. Just now I talked about the degree of occlusal interdigitation. So I want to share with you all some of the observation by other researchers that if the occlusal interdigitation is lesser to is not proper, so that is more likely to allow anterior-posterior movement of the teeth. Okay. That means space loss, if any, because of the caries or because of the extraction, there will be more loss of the space. Another researcher, 1951 to 61, spoke of the cuspal interlock. अभी मैंने आपको बताया था cuspal interlock, and advised that cases with the good interdigitation would lose less space after premature extraction. Okay. And other researchers have the similar observation. Morris stated that the interdigitation had played a role in the extent and direction from which migration would fill a leeway space. Similarly, he conjectured that space would be lost more slowly in the neutro-occlusion than in the H2H relationship. H2H means flush terminal. If we have a flush terminal plane in the deciduous and end-on relation in the permanent, then space loss will be of the different kind. And if it is a mesial step or the class 1 or the class 2, there will be a different type of the space closure, be it caries or be it the early extractions. Differential lip pressure. There is a probability of accentuated drifting of anterior teeth in extraction space due to the muscle pressure. And therefore, if the class 2, there will be a lip trap or there will be a active mentalis muscle and posterior pull by the orbicularis oris also. So there will be three muscles acting on the jaw or also on the lower teeth. So that will cause a faster space closure. Okay. And in that cases, you might be familiar by now that lip bumper will be your treatment plan. So orientation, Sibling on the Bolton plane concluded that the teeth could only move forward. All the teeth, according to the cranium and dental relation in the alveolus, that teeth should move forward only. But he explained the distal migration seen in the certain teeth as a function of applied muscular force only. So the muscular force should be remembered in any type of the arches, together with the TSLD. TSLD means tooth size arch length discrepancy or the canine or the transverse width. So class 2 diff to malocclusion will have a greater lip pressure that maintain the retroclination of the upper incisors. So there will be increased space loss should a primary molar loss occurs. Okay, that will be space loss will be faster from the anterior side, that is from mesial side. Class 2 diff 1, flaccid perioral muscle, large overjet, possibility of lip trap or the hyperactive mentalis, increased pressure on the lower teeth and accentuated space loss due to the posterior drift of the anterior teeth in the mandible in case of premature loss of the D. So D, very often in the DCA examination also, we do treat pulpectomies or we do have cases of the space maintenance for D space only. So D is very important. In the coming slide, you will know it. Consider D your bread and butter, and the interdigitation your bread and butter, and the closed space arches your bread and butter. Class 1 borderline, class 1 with open space arch in the desiccation have a normal tonicity, and you don't expect actually, apart from the muscular forces, there may be space closure, there may not be, but you expect it will be a normal case. While in closed deciduous arches, or there it can change into the borderline or the severe crowding, and there will be accentuated space loss in premature extraction space depending on the area of crowding. If there is a larger incisor space discrepancy, or the incisor in the second name is of incisor discrepancy is incisor liability. Okay, so if it is crowded, there will be faster space closure and relieving of the crowding in the anterior area. So the crowding will be adjusted, crowding will be shifting to the middle area if there is any caries or the extraction of the D. Therefore, a space maintenance is strongly needed and to compensate muscular influence, but the design should be little bit changed. Now, by now you understand the space is affected by growth, that is class 1 or the class 2 or the class 3, muscles and the dentition itself. So there are 3 angles or 3 cornerstones which should be considered. So what should you do in an early mixed dentition? Whatever treatment is there, we should do whatever intervention is to be done, we should do in the early mixed dentition only, because you can counsel a parent, counsel a patient, there are chances of the crowding, but you start intervening those cases in the early mixed dentition only. Okay, so what we should do, how would we know what type of arch is this, whether it is a open arch, have a favorable TSALD, or it is a borderline arch, or whether it is a severely crowded arch. For this, we have to go with the wire method, brass wire method, space available minus space required because of the erupting tooth and existing tooth. For this, you need mixed dentition analysis. Okay, so mixed dentition, how many of you do the mixed dentition analysis? Kindly go for, if you can answer in the chat, I would be happy to know. How many of you go with the mixed dentition analysis? Kindly fill up. None of you have answered. Let me know. Nobody is listening me? You go for the Moyer's analysis, head to Itana. Anyone else? At what percentile you go? Tanaka Johnson, Nehal Ahmad, very nice. Anyone else? Hathwi, Dr. Hathwi, which percentile do you go for the Moyer's analysis? Answer fast. Tanaka Johnson. Ma'am, depends on the case. Percentile you choose according to the case? That is not related with the case, beta. Tanaka Johnson, Moyer's analysis, Tanaka Johnson. I would like to know how it depends on the case. Very nice. Tanaka Johnson's and Moyer's analysis. What percentile you choose for the Moyer's? That also I would like to know. And whether you have developed any regression formula for your population. Okay, keep answering. I'll see. 75%, 75%. 75 for percentile for the Moyer. Okay, so most of you go for the 75 percentile. Okay, nicely. Nice chatting with you all. So by that, And you go for the TSALD, tooth size arch length discrepancy. Nice. Yeah. Anyone else? Shwetal, yes, ma'am, you go for that. Okay. Thank you very much for responding. Keep responding. I'll see afterwards, after end of this lecture. Okay, so TSLD, by this TSLD, you come to know if the space discrepancy is 1 to 2 millimeter, that is minimal crowding, or that will resolve by itself, or it may be zero also. And then you go for the, if there is a borderline arch or the severely crowded arch, if it comes, that is more than 4 millimeter. Okay, no, sorry, more than 2 millimeters. Borderlines are 2 to 4 to 5 millimeters, we can say. If more than 5 millimeters, it is severe discrepancy. Okay, so then after you should go for the, for the segmental type of the space analysis, where you can take advantage of the leeway space and the incisor liability together. Okay, my goodness. So this is incisor liability is a space many at the many places it is written space available minus the mesodistal width of the permanent teeth, permanent incisors. Other places it is written, it is a difference of the mesodistal width of the primary and the permanent tooth. So there are two contradictions. Okay, better to call it as an incisor space discrepancy. This term is given in the Nakata and Stephen V books. So I like this term, that is away from any controversies, and actually it means space available, and for space available for the erupting incisors. Simple. So we can calculate it. So that I have incorporated this term. In my app, incisor space discrepancy. Okay, be clear. So it is incisor liability actually. So space available is between mesial of the canine to mesial of the canine of the opposite side in maxilla. So segmental arch, you need to sum up all the teeth, and you will know incisor space discrepancy in the anterior region and buccal space discrepancy in the posterior region. For this, you will calculate the mixed dentition, the predicted combined width of the permanent canine and the two premolars with the mixed dentition analysis, and you can subtract this. So buccal space discrepancy and both of the things you will get separately. And in the mandible, the primate space is distal to C. Here also mesial of the canine to the mesial of the canine in the mandible, and accordingly you will calculate it through the app, because and app is just a finger application away. You can go with the Tanaka Johnson, you can go, there are many types of the mixed dentition analysis is there, and Moyers also include 5 percentile to the 95 percentile. Okay, 5, then 15, then 20, 25 percentile, then 35 percentile. So many of the percentiles are there. I would suggest you at least take 10 of the Shobha ma'am also is there, and Yash is also there. 10 of the permanent cast, and you just see what type of percentile in the Moyer is more closer to your the value, more closer to the value of cast you have in okay, because the area wise the percentile may differ. Whole of the India is taking 75 percentile, but it may not be true, while Tanaka Johnson is a regression formula that is more close. So accordingly you can develop your own regression formula. Okay, there is a chart given that I will be telling tomorrow, but first what type of arch you have with the help of wire type, wire analysis, circumferential analysis. Then you should go, if it is a borderline or the severe, then you should go with the segmental type of the arch analysis. So let comes, now you have found first transitional phase in the spaced primary arches with the TSLD 0 to 2 millimeters. The expectation is space dentition, exchange of incisor is almost always it is favorable until unless it is there is some type of muscular habit is there. Incisor liability is minor in maxilla. It is minus 6.2 on average, while in mandible it is this. Interdental spacing is present. It is compensated with interdental spacing in maxilla and mandible. Incisor positioning. Okay. First, for the incisor positioning, you should understand in the maxilla, incisor comes in the anterior position. Okay, means in the protrusive condition. The axial inclination is more forward. Okay, while in mandible it is behind that, and with the lingual pressure, with the tongue pressure, it comes forward. Okay, if any of the muscular habit is there which is retroclining, the maxillary incisors will not allow the mandible incisors to come forward. Okay, so the maintenance of overjet and maintenance of the axial inclination is important while the incisor exchange is taking place. Okay, so circumference of the arch is very important to maintain in the class 1 also. Okay. So if you are not putting a space maintainer for lost anterior teeth, that is not good. Although in grammar it is written, but it is any type of the environmental forces may occur, and it is not always that space will not close. Okay. So first transition phase of the incisor exchange, you see there is a smooth exchange. In spite of there is a caries in the D, but there is no space loss from anterior or from the posterior. So this is a benefit of space dentition. And you know the axial inclination is almost straight in these type of the patients. You might have seen severely crowded patient also in the adult dentition, which almost always have a straight type of the incisors. Straight inclination is there, and many type of the. I don't know whether your observation is there. Please start observing. Some have little protruded teeth, but with a good broader smile, while some have a straight teeth. Teeth are rarely visible in while smiling. So the both are the arches which are non-crowded, but they have different patterns. Okay, different space conditions. Here the space maintainer is easy. Before eruption of the 6, you can give any type of the space maintainer, because that's just you need to maintain the arch. Okay, but as soon as the incisor exchange is taking place, you should go for circumferential management, that is lingual holding arch, and that is indicated once the incisors are erupted and multiple extractions is there. So that will prevent the labial forces on the anterior teeth, and that there will not be any collapse of the anterior arch. Now coming to more importantly and very controversial thing, this must be your bread and butter after your MDS. That is transition in the closed primary arches, which have a TSLD from 2 to 4 to 5 millimeters I can take. Okay. These type of the arches, almost always, you just observe from now, almost always, I have observed in more than 90% of the cases, always have a borderline or the flush terminal plane in the E and end on in this. So this here, there will be a space loss from posterior also for the class 1 correction, and from anterior also there will be a juggling if any of the crowding is there in the incisors. So that will shift very easily posteriorly. Now in this cast also, you can see this is a carious D and there is a large overjet. There is a collapse of arch from this side. There is no interdigitation in the canine. You can see it is lingually placed. It has tilted lingually, and it is going posteriorly with the eruption of the lateral incisor here. It is not seen here in the cast, but with the eruption of lateral incisor, it is putting pressure on this canine, okay, and then on this D. Okay, so there is a space loss here. And there will be a space loss from this side also. So this is a two-edged sword. Closed primary arches or are the two-edged sword. Okay. So almost always these have a flush terminal plane. And this calculation is given in my app that if you want to save the leeway space, you do not add this space. And if you want class 1 correction, you have to add this space. Okay. For the late mesial shift. So when primary incisors are lost, mutilated, and have a different axial inclination because of habit or because of any muscular pressure, before the first transitional phase, what happens? Incisor exchange, thus caries in anterior teeth cause malocclusion. So contrary to belief, it does. Always replace it because that is the area of proprioception. Please go for the proper appliance in this. Otherwise, there will not be any motor skills developed for the placement of mandible. Where to place the mandible? And this is a patient of ECC, severely mutilated cases. It should not be done. We should go for the any type of the treatment, be it removable, be it fixed type, post and core in the deciduous dentition, any type of the treatment you can go, but create a stop for these type of the mutilated teeth. It is not, it does not need any space maintenance. It does need. So this is developing, now it is developing class 3 just because the restoration is not done. Loss of anterior plus canine guidance for the placement of the mandible. So motor skills are not getting developed and growth center in the TMJ is getting changed. So it will become a permanent class 3, but at this time it is a class 3 developing only. Loss of proprioception, and there is lack of neural feedback, and there is no learning of motor skill, and so slowly the mind also will forget what was the actual mandible position was. Okay, so this is always should be done. Now here it is, I have shown it to before. This is because of the maxillary tooth. And here also you can see it is a functional shift of the mandible towards this side, towards the side of this arrow. Check bilateral occlusion. If the midline shift is there with the imbalance bilateral occlusion, then you should go immediately for this because this is a proprioception and this is a wrong motor skill patient is learning. Ultimately, the both side of the growth center in the TMJ will change its position and permanently it will be encrypted. Then only the dental means we will go with the malocclusion correction with the fixed orthodontics or 2x4, whatever mechanics you are applying, but the TMJ are damaged. So before, in another lectures, I always say treat TMJ first, then bone first, that is maxilla and mandible first, and then you, according to that, you treat your teeth. Okay. This is also class 1, that is mesial step. Before eruption of 6, it was given. The space meter given before eruption 6 worked well, which are in process of eruption till now. 6 is erupting till now. But you see, again, at the time of photo clicking, the picture was donated by Dr. Vaibhavani. So I asked him to please consider this, go for the Catalan appliance immediately. And you can see that developing mandibular incisors crowding because of this maxillary teeth. Okay. And at this time, we should go for all the diagnostics, whatever we can go. What is the incisor liability? It is very clear that TSALD is not sufficient. It is more than 2 millimeters, 100%. but is it a space loss or not? Space is not available at all. Actually, it is a space loss. It is a collapse of arch. We should regain it by means of uh, treating the maxilla first. Okay, you can see the developing crowding. Okay, first this should be corrected, and then other things. So the traditional examination of mandible only for the crowding in the textbooks till now, even in Nikhil Marwa or any of the, we go for the mandibular arches for the any calculation. What is the future of the how much is the, if the mandibular arches are diagnosed with the crowding, that means it is patient is of crowding. No, it is not. It is always dependent on the maxilla. If the maxilla is corrected, mandible follows. 100% it follows. And therefore, always examine maxillomandibular relation and look for any environmental forces for changed axial inclination of the individual teeth, be it habit, pencil habit, or the nail chewing habit, or lip sucking habit, lip trapping habit, even the posterior lateral tongue thrust, anterior tongue thrust, cheek sucking. Many type of the habits may be there. Or simple, patient has a tight skin, burns, anything which are playing role on the maxillary or the mandibular arch. Also the class 1 or the skeletal class 1 or class 2 or the class 3 have a different type of the. So first we should correct the muscles. That is why myoforce appliances are very successful, because they remove all the muscular forces from around the arches and arch grows. Look for any environmental factor that okay. So let's move to more complicated cases in the overall crowding, that where the first incisors D is carious and some problem is there because of the space loss, cause of the space loss. See the I have shown this case, ectopic canine in the mandible and the maxilla also. And here is the another arch which shows a severe crowding. So are both the cases a result of tooth size arch length discrepancy? Think it. Remain thinking. So I'll tell you the answer afterwards. Effect of caries and the lost teeth during incisor exchange and borderline space condition of the arch, that is TSCLT 2 to 4 millimeter. With the wire type, while for the segmental, it will be little different. So this is a norm in the primary arches. Normally, it is closed space arches with a good facial balance. Okay, and they have a flush terminal plane almost always, be it crowded or be it may be borderline or it may be severe type. Normal facial balance in the crowded arch. Okay. So here the how does the incisor exchange take place? Incisor liability is bigger. Interdental spacing is you can consider it is as such 4 and 3 in maxilla and the mandible. Intercanine arch width increase in the crowded arch. In the closed space arches, it increases by 3 millimeter in both the arches, maxilla and the mandible. Incisor positioning, that is increased axial inclination towards increased axial inclination, that is 2.2, 2.2. And you can see crowding is, there is no crowding in the borderline arches. So this is a precarious condition where the arch can go to the severe type of the crowding if we are not vigilant enough. Intercanine arch width is given in this only, and this is, I have taken it from Dale and Dale from Interceptive, not there is a one book, Current Principles and Techniques in Orthodontics by I'll give you the reference. So from that chapter I have taken this, and it is always, you might आप लोगों ने भी पढ़ा होगा कि it is more in the crowded arches, while it is not, there is no or very minimal increase in the open type arches, and where the crowding is not expected. Okay. So incisal liability compared to the space dentition, it is bigger in this, and it relies on the secondary spacing only. Secondary spacing is not there in the open type. Interdental spacing is, we have taken common. Incisal positioning is also common, but here it is 0. So what is secondary spacing? Let's know. It is a closed arch, secondary spacing occurring during the eruption of the permanent incisors. In the maxilla, you can see the crowding in the lower arch. It is lingually placed. If there is any space, it will come forward with the lingual pressure. And with the secondary spacing, you can see there is a gap in this. This is a little wrong move. But once this spacing is closed with the eruption of lateral incisor first, okay. So this also is a ugly duckling type in the closed space arch. While in normal arches, there appears at the time of the canine eruption. But in the closed space arches, this is also an ugly duckling type. Space in the, you should never treat this type of the arches with any mechanics at this time of the incisor exchange. Let lateral come, because with the wedging action, the lateral teeth eruption, this space automatically closes. Okay. So what happens? Mandibular teeth erupts first and then followed by the maxilla. Once the central incisors are erupted, there is lateral incisors start erupting. This erupting lateral incisors put pressure on the canine, and if there is a good interdigitation between both of the canine, this pressure is transferred to the upper canine, and which increases the intercanine width. Okay. So at the time of lateral incisor, this is very important. If the lateral incisor is erupting, okay, you should not give band and loop incisors. The loop, okay, which engages the canine both ways, from lingual side also. That in that case, canine will not go posteriorly. Posteriorly and buccally. Okay. So in this type of, the pattern of eruption is different. Pattern of space closure is different. Okay. And therefore, the designing of the space maintainer also should differ 100%. And there will be a space, there will be a different treatment plan for space management in these patients, for the relieving of the crowding or for anything. And there will not be any further increase in the intercanine arch width once lateral incisors are fully erupted. Then any type of the space maintainer you can give once it is erupted. You can see the wedging action of the lateral incisor is closing the space and it will fit itself. There is a secondary spacing, there is a good interdigitation in the deciduous canine. That is more important. If it is intact, suppose it is not intact on this side, there will be a loss of space and this lateral incisor will move more, and there will be a collapse of arch from this any side, wherever if the D is carious or the canine is carious. So what will happen? It will move distally only, distally and lingually. Okay. So this interdigitation should be moved, and you should see in all the patients. And no treatment should be delivered for this. And there is no need to see what is there. The thick frenum is there. It will go up. Okay. It will get the fibers will go up. It will shift up with due course of time. After the eruption of canine, it will be all right. This is the studies. These are the studies by Maurice and Chadda, in which you can see lower intercanine width. At the age of 8, it remains static till the age of 18. Okay. It is followed by, this is the original research. It has been followed by many research which also have a similar. I know I ask many person when intercanine width increase, actually they say at the time of permanent canine. No, it is for the first incisor exchange. Whenever it is taking place, it is it increases that, and the permanent canine follow that path. Although exceptions are over there, but in general, in 80 to 85% cases it happens. So for the segmental arch analysis in these type of the patient, you start calculating if any abnormality is there, of any crowding is there in these type of the cases, you start calculating and always start from the outer side of the contact points. Okay, if you are taking from the inside, there will be a difference. If you are taking from inside, it is only 9.19, while if you are taking from outside, it is 9.88. Okay, this is a common mistake we do, and it results in the extraction type of treatment plan. So these borderline arches should be detected, particularly compared to the spaced and severe crowding arches. These are the arches need the smart space maintenance the most in cases of proximal caries or the early loss of the teeth. Space maintenance are contraindicated for severe crowding arches. Okay, it is given in Mathewson if anybody has read it. This needs a proper treatment planning and start doing the space supervision or that extraction approach. That means serial extractions. So space maintenance we do give. I have seen the modified lingual holding arches where the incisors are erupting lingually. Please do not go for that. Go for the segmental arch analysis. Start treating that cases. Sorry. So here is a closed spaced arch in the primary dentition, early exfoliation of the primary incisor, and you can see there is a early space loss, rapid space loss, and because of this collapse of the arch, you can see the lateral incisor is striking on the lower teeth, both side. Okay, and there is a disocclusion of the posterior teeth, and probably if it continues and no space maintainer is given for that, overjet maintenance is very important. That is why. Okay, and if it start collapsing, so what will happen? There will be a functional mandibular shift to any direction, anterior or the lateral. Always replace the primary teeth. Now, effect of the carious teeth at the time of eruption of lateral incisor in borderline cases, you can see the lateral incisor is erupting, which is putting force on the incisor, central incisor, as well as in the D, as well as in the C. Okay, so what happened? Effect C is moving distally only, while it should have increased the intercanine width. Means canine should move laterally and distally, but there is only a distal direction because B is either extracted or it is carious, while the inclination of this permanent central incisor is corrected by itself, but there is less space left. So be vigilant. Here the canine is still anterior, and probably this canine, I have not followed this case, I just found it. So I just took a picture of this patient. While this canine will move distally and buccally, both, and there will be a good eruption of the lateral incisor, and it will move anteriorly, and the angulation also will correct. Understood? And there will be a space closure in this. This is a borderline type. There is no need to do any treatment at this time. By now, you know so many of forces. The D is very important, although you might have read maybe in the journal clubs that there is no need of a space maintainer for D space. But actually, it is a culprit.
X-ray proper નથી રૂટ્સ ની આઉટલાઈન નથી ગ્લેઝી છે
Sorry, what did you say?
ગ્લેઝી છે એટલે
What did you say? Time is up. Sorry, I could not listen.
Ma'am, actually, one of the participants' speaker was not on mute, ma'am. It was a glitch, ma'am. Sorry, ma'am.
So there is forces from posterior side, late mesial shift, mesial tipping of the six. Direction of the growth is also anterior and forward in the of the mandible. That also keep keep the teeth moving forward only. Also, intercuspation is important, whether interlocking is there or not. Tipping forces from the tooth erupting distally. Okay. So, and from anterior side, lip forces, habits, forward growth of the mandible. Forward growth of mandible. Baum actually had explained this mechanism. So there is a mandible always moves forward and downward. Okay, that is a normal thing. What happens? What the muscle that is orbicularis oris, that puts more of the pressure on the alveolar arches in the maxilla as well as in the mandible. So there is more lip forces from forward from the anterior side. Again, the incisor space discrepancy may be there. Maxillomandibular relation may be defective, that if because of the habit maxillary axial inclination is changed. Stage of eruption of the mandibular lateral incisor, intercuspation of CC both sides, presence of any proximal caries in the arch, and versus the space condition. Okay, so all these things. So this is uh, any loss, any caries in the borderline arches, you think malocclusion is developing. Just looks have a look, good look in your arch. What is that happening? What malocclusion? Very commonly lateral shift you will find 100% in the borderline arch if the caries is there. Caries is always chronic and gives time to move into the carious space in the borderline arches or the most severely crowded arches. 100%. Okay. So these are the borderline arches. This is taken from the Boucher. I remember this. So there is at the lateral side, you can see this is a modulus. Insertion of 8 muscles are there. So there is a greater pressure on the D space. There is a greater pressure in the premolar space. Okay. So there will be apart from anterior, apart from the distal side forces, there is a lateral pressure from this modulus. Okay, and patient if is a thumb sucking habit, you see it will suck. There will be a much more great pressure from this side, from this modulus. This only will shrink. This only will suck the thumb, and there will be a transverse dimension loss will be from the MPV area only, from the premolar area only, from the D space only. So D carries, that means something is occurring in your mouth. And these cases, that is a clue. And so lower anterior the labial teeth are labial to the bone supporting them. Incisal edges of the labial, incisal edges and the labial surface of the lower anterior teeth are labial to the bone supporting them. Okay, that is taught while making the dentures. Inclination of the labial plate of the bone and the labial of the upper anterior teeth causes upper lip to function on an incline. It is easy to observe lack of support of lip that would result when artificial anterior teeth are positioned over crest of the residual ridge. Resorption of the alveolar process in this, leave that, but we can simulate the things. These are the studies which which is simulated in construction of your complete dentures. So I just remembered this picture. So I have taken this from Boucher only, that borderline arches always arrange themselves by axial inclination, increase axial inclination. Okay, so that we can change it by doing the segmental arch analysis. We can change the axial inclination, we can change the muscle forces in that, and that will be readily adapted by the patients. So that is a clue. In nature also, if this is an open arch, they will have a straight incline. If this is a borderline arches, that will always have a more visibility of the teeth, that is anteriorly inclined. Understand the closed space and the open space arches, there is a different mechanism both. So what will happen? There will be a loss of space because of this orbicularis oris and the modulus at the corner of the mouth, and there will be arch collapse. This will move distally only, while it will move distally and buccally. Again, one more is there. You can see this is a crucial case. This is another case I have shown here, that you can see while eruption of the lateral incisor, what has happened? It is totally moved distally only, and there is lack, and this could not straight by itself, because lateral incisor here, in here, it is erupted first. This has corrected, and this has moved this central incisor into the midline, towards the midline, and this could not take benefit. Okay, this eruption, lateral incisor did not erupt before this lateral incisor. So what has happened? It has moved distally, because lateral incisor has moved canine distally because of this carious D, as there is a lack of space. And here, this is a pathognomic sign of this midline diastema, secondary spacing in a borderline arches. Okay, everybody, please listen. Do not treat it with reciprocal forces. Lateral incisor should correct it. So what is happening? There is a lack of space, and it is not able to erupt now. So what we have to do, we have to move this tooth a little bit out, and we have to put both the teeth in plane. It will erupt by itself, and then provided you have to maintain the circumference, not the nance palatal or the transpalatal. Nothing. You have to go with the circumferential type of the space material in these borderline arches, because there is a collapse because of the muscle forces around it on the actin. So the design of the space maintainer will change in the borderline arches. Please understand this. Okay, this is another case, primary dentition closed arches, and you can see this is lateral incisor is overriding the maxillary incisor, and here I could find this is my son only, and I was not knowing anything about the borderline arches that time, but I just followed it. Patient, the son had a caries in D. You can see patient, he is removing something fiber from that side, grossly caries phase 4. I had treated also this, but could not be successful. Now you see, because of this lateral incisor erupted, all the teeth have moved to one side, and there is a impaction of canine. I have seen many cases in the previous slides that there is an ectopic canine. Okay, ectopic canine in all the cases, whosoever had a borderline arches. Here also, this is going to impact. Okay, and all the axial inclinations are changed. But luckily, still lateral incisors are erupting. Luckily. Here the axial inclination, you can see it is quite good. IMPA is 110. That is, it is, this was, the X-ray was done, CT scan was done for his migraine actually. And probably there was some TMJ lateral shift. And that is why my son had some kind of migraine that doctors could not diagnose, and they prescribed the CT scan. But now I understand there was a collapse of arch from one side, and there was some lateral shift, and there was some TMJ unequivalent TMJ pressure. That is why he had a migraine. At 10-year months, there is a IMPA is 110. And this is a full-fledged arch. What I did Holly appliance with spur on distal 2.2 and 2.4 to hold the leeway space, and the wedging effect of erupting teeth increase the arch dimensions, circumferences by itself. Okay, and there you can see the good interdigitation, straightening of the teeth, and just I did this, I took care of the circumference of the, it happened by chance, I gave a Holly appliance. nothing else. And everything is managed by itself. Patient is quite stable, happy patient, that means my son. Now he is now 24 years now. Okay, so this is a big smile. You can see the visibility of the tooth in borderline arches. But that my son taught me the pattern of eruption, and elder son has a spaced arch. His visibility of teeth is lesser. So both have a natural arches, different type of the space condition. So what happens when space condition of a developing arch is ignored, and does giving traditional space method accentuate crowding? Yes, it accentuates, because at the time of lateral incisor erupting, this condition is not taken care. Okay, now that it will accentuate, it did not relieve. Can we do some intervention that crowding should relieve? Yes, we should go. We should go for the segmental arch, first TSALD, and then we should go for the segmental arch analysis, and then we can relieve the crowding. Some of the cases, a 7-year-old history of extraction of this disease, 74546465, 1 year back. What kind of a space meter can be given the maxillary arch? Patient is asking. This is a page from Facebook. 1/6 only cusp descent. You see the lateral incisors are erupting, and now there is no room for canine to go move distally. Okay, both the cases here. And what has happened? There is a space loss, and it is getting impacted. Lateral incisors are getting impacted. It is not able to erupt only. One more case I will show you. Yeah, this. See, the parent is asking, hoping to have a consult soon with the orthodontist. See, the orthodontist. I hate this term. Orthodontist does not know anything about the eruption pattern. Be the master, be the physician. I always say, my student, be the physician of your child's mouth, not the orthodontist. Do not copy orthodontist. For my 7-year-old child, 7 years is the ideal age for the eruption of the mandibular incisors, etc., etc. So what is happening? This is, you can see the pathognomic sign of the spacing in the erupted permanent central incisor. By now, probably it is a borderline arch, okay, which is dependent, intercanine width increase is dependent on the answer in the chat box. Answer in the chat box. Increase in the intercanine width is dependent on the eruption of which tooth? Please answer. Lateral what? Lateral what? Mandibular or mandibular? Mandibular or the maxillary? Which one? Yeah, very nice. Mandibular. Very nice. Yeah, this I wanted to inculcate. Lower anterior, lower lateral incisors. Very nice. Thank you for listening carefully. Found a good answer. So here it is the, you can see the spacement error. Here given band and loop, ideal band and loop, which is maintaining the space for future eruption of the premolar. Only premolar is given all the emphasis while giving the spacement error. Why, bhaiya? Kyun? The patient has a different space condition. Patient has a different type of the eruption pattern. Know your arch. Please allow the lateral incisor to erupt. Please allow lateral incisor to increase the intercanine width. Please allow the lower lateral incisor for the increase in intercanine width in maxilla as well. Then only lateral will erupt, and patient is suffering. Her only 2 incisors are erupted, but lateral incisors are not erupted. Parents बेचारे परेशान हैं. But this is, I should call this is iatrogenic malocclusion, because you don't know. No, so this should not be done. These are 2 examples. This also I have taken from Facebook group, some of the Facebook group. Yeah, this is something myofunctional. Myofunctional, myobrace, because it is commercial, and parents will feel something heavy is done. then it will correct. Of course, it will correct, but without a space maintainer. Unless this space maintainer is not removed, it is not going to relieve any crowding. So borderline cases during the eruption of manual incisors. So design of a space maintainer, it should not be that what we give laterally. So this is an article by Robert Rapp, Demiros. I think Dr. Yash might be knowing about this article. A new design for space maintainer has been proposed by Dr. Robert Rapp. Now I start calling it it has a horizontal bar, just a straight bar, which is distally directed. And lateral incisor is erupting. Hopefully, it will go distal. It will move distally, and there is intercuspation is also lost, but it will work in the mandibular arch at least. And you can see the secondary spacing, the maxillary arch. It is about to. These teeth are mobile, and it will erupt very nicely. Eighty to 85% of the patient has this type of the crowding as a liability from 1 to 4 millimeter. So at this age, when the lateral incisor is erupting, we can take advantage and we can start with the space supervision. That is, I'll tell you in the. This is an article by Bell, R.A. and Sonis. All of you can read it. So what happens when caries D is not restored in the borderline arches? It is this ectopic canine. This is a student from some dental college only. I asked her whether you have a TMJ problem. She said yes, she is suffering, and she is using a soft aligners for that, soft splints for that. Now you can see there is a collapse of arch. Lateral incisor, straight line it is, this is distally moved, and there is a lack of space, and there was a carious patient had a history of that. And there is a lateral mandibular shift towards the right side because patient is closing her mouth inside this space, and there is a crossbite on this side. This is another patient I have showed you. So this is my patient in Indore only. You can see I just this is all these are the retrospective studies. When I start studying the borderline arches, I found many of the D culprits. You can see the D space here, D space in the mandible. And because of the crowding, I was going for the serial extraction. The patient did not come and became my study material later. So this patient, this was the patient who could not take benefit of interceptive guidance of occlusion by extraction or the non-extraction approach. And this has happened. There is an impaction of canine and ectopic eruption, not impaction, there is ectopic eruption. And what happens for this patient went to the orthodontist. This was a borderline, got complicated just because of the caries C and D and failure of detection of the arch collapse due to that, and failure to provide a space maintainer of appropriate design at the right time to prevent arch collapse. And there is a failure to preserve arch width and palatal volume. and the case is currently being treated with the 4-4 extraction by the orthodontist. And this was not a 4-4 extraction case from the beginning. Okay, so we should take care of that. We should not transfer our cases, or we should not gift our cases to the orthodontist. Be vigilant. And there are some treated cases by space supervision in which e-space, by we start. Everybody know there is a leeway space is always available for the adjustment, and by holding the leeway space, we can gain some of the space. Okay, and by that we go for the sequential slicing of the deciduous teeth, starts from the canine, then for D, and then for the E. But we do not extract it. We just go for the sequence, and it just we go for the sequential slicing, because we want to maintain the circumference of arch also. Okay. So these are the cases. Patient started in the 2016. There is a mandibular and maxillary crowding. Patient has a normal soft tissue profile and well-balanced muscles. This is a, you can see there is a flaring and there is a lot of crowding in the mandible and the maxilla. So we started incisor liability is -4. These are my old app. This is my old app where I took a screenshot. But now the proper download form is there. I hope all of you have, in which you can note it down. There is no need of a screenshot. If you want, you can go for the screenshot, but you can note it down and you can record it. Your documents can be recorded in your department. So incisor liability is this: increasing in arch perimeter, we can gain 1 to 1.3, and lip bumper to remove the muscular influence in the lower arches, and holding the leeway space will add +4 millimeters, and by that, by the incisor liability, that is -4, is compensated. We will have a +1 to 1.3 millimeter excess space. Likewise, in the maxilla, it is -5 incisor liability. Increasing the arch perimeter, we will have +2. Holding the leeway space, we will have 3 +3. These are old terminologies. And now I have replaced is incisor space discrepancy and buccal space discrepancy. So buccal space discrepancy is +3. Okay. And while incisor space discrepancy is -5. So we can compensate it. This here in maxilla, we have 0. That is, we can go for the space supervision. That is sequential slicing till all the permanent teeth erupt. 2/4, because the incisor was erupted, and it gives us softer forces. So just we aligned it to increase the arch perimeter, and here we have given lip bumper. Sequential slicing of the tooth. First, the C was slices. I don't have the sluice way created in the C. I don't have that photograph. So this is slicing of the D for the eruption of canine. It is directed distally. Once all the correct yourself. I know lecture is becoming little lengthy, but please understand for tomorrow's workshop. Okay, do not speak, do not disturb. So this is what I was telling. I took care of the circumference of the arch. Dens palatal will not do anything. Dens palatal will prevent the mesial migration of the 6. Okay, that is the only work. But I want to preserve the arch circumference. So that is a palatal type of space maintainer. It is called a palatal bar. No. Space maintainer is given. It is given in the literature and lower also. So you see the development. It is approximating the permanent dentition. These are the changes in the arch. It was started in 17. then 18, and then it is 19. Everything is within 2 years, everything is resolved. And this is 22 में मैंने इसका लिया था 27/1/22 को. So arch is stable. I got transferred at Aligarh, so this is still remaining. I would have corrected it if I was there. So there is a severe crowding. You can see this little bit of canine. It is still labially placed, but it is not too much that it does not look like ectopic. So still we can go with the interdental slicing and it will correct by itself. Patient is happy. Another case of the severe crowding type. Here the sluice was created, discrepancy was calculated, and Holly appliance. I always prefer Holly appliances. And the sluice was created by giving the inclined slice on the canine, on which the lateral incisor can slide anteriorly. That mesodistal dimension at the buccal aspect is maintained, but it is reduced from lingual to mesial side. So this will start sliding on this by the lingual pressure and it will arrange itself. Let's see whether it is arranged. Yeah, it got arranged. It is arranging in this. And you see the severity of crowding is relieved by itself with the lingual crowd, with the lingual pressure, and upper is also getting corrected. And this is a sequential slicing of the teeth we planned. These are some of the photographs. After slicing, you can see this is a bulge below which the premolar is getting impacted. I sliced that, it is erupting now. Okay, it is. And many times there should be a deep slicing. There is a enamel, little bit of enamel is remaining, but it should be chipped. And where the premolar is getting rotated because of this. And therefore put a separator and you should go with the deep slicing and just clear it off. And then it will get corrected by itself. Likewise, here is a wedge. Slicing is not done properly. Here it is getting impacted again. You see the mesodistal dimension of this second premolar is always less than the E. We can still slice it and slice, it will erupt. Yeah. Patient has a good smile, but patient has a receded chin and it was planned by the oral surgeon to go for the rhinoplasty. Then patient will have a good maxillomandibular profile. Tooth dimension and everything is good. This is a receded chin only. So chin advancement after the growth completion will be done. But this is not free from complication. If you are going for space supervision and holding the leeway space is not free from complication, it may impact the second molar or the third molar. So that is also iatrogenic malocclusion. And spacing was measured from इस तरह से इसको करते हैं. You just can go for the further reading from Andrews on this. This is, you can take a screenshot. Okay. Another parameter is how to do at least intermolar angle. You draw a straight line from the long axis of the teeth of 6 and 7, whether it will get impacted or not. At least intermolar angle should be at least 24 millimeter. That means IMPA should not be less than, should not be more than, कितना होता है normal, 24, 25. Yeah, उससे ज़्यादा नहीं होना चाहिए, because that will result in a long faces, and in the long faces, always there is a backward and downward growth of the mandible in which all teeth tip mesially and there will be great impaction. There is less volume in the mandible to hold all the teeth. In those cases, serial extraction is better. Okay, so space supervision should be limited to the horizontal type of the horizontal growers only, in which facial balance is good. So in terms of risk and benefit consideration relation to the non-extraction treatment, passive lingual arch therapy for space gain should be critically reevaluated against alternative modalities in orthodontics such as anterior arch expansion. So if you are considering measuring the MPV, if it is deficient, go for the arch expansion first. Okay, when everything is normal and there is a high labial pressure on the arches from the side and from the front, then in those cases you can go with the and also the patient is horizontal grower, then you should go for the leeway space preservation and the space supervision arch. So this is a horizontal grower, this is not a long face patient. Here, this is a new app download form. Here I have given all the percentile from 5 to 95. You can just fill it up. Which one is closest to your permanent cast? So you have to study your permanent cast first. Then you will know at which of the percentile we should follow. You should follow. Tanaka Johnson is also given backman, trackman, and regional formulas are also incorporated in the app. The person who has given me the region formula, they can go with that. And Hukabas is also given and predicted combined with everything is given, just you have to fill it down. You can make a study with the help of app also, just by filling the values here. Here, some of the calculations are there for this patient. That incisor buccal space discrepancy is given, segmental arch analysis logo is there, buccal space discrepancy and the incisor space discrepancy both are given, and then you add everything. If it comes to 0 or more than TSLD, if it comes in the positive, that means you can hold the leeway space. So in the mandible, we have gone for this. In the detail, I will tell you. Buccal space discrepancy is in minus 1.4. Okay. While the incisal space discrepancy is -4. Total is minus 5.4. Okay. And this is if patient is borderline. If we go for the class 1 correction, it will increase. It will become minus 6.8. Okay. So how to compensate? The treatment plan is to increase the arch perimeter. That means by proclining the anterior teeth and by holding the leeway space. That is minus 1.4. It is there. I'll tell you. And by holding the leeway space. So new leeway space became 1.8 and 1.3. It is different in all the patient. It is not 0.9 in maxilla and 1.8 in mandible. Please do not think it is always same, because there always lies a Bolton's discrepancy. There always lies a individual nutritional status and genetic status, everything. So always go the customized one. So total is plus 3.1. Okay, so increasing arch perimeter has become plus 2. It is now new deficit is minus 3.4, and by holding the leeway space 3.1, and your 0.3 is remaining, but that will be interdental slicing can be done. So this is compensated, and the treatment plan is space supervision. Okay, so this is how we calculated first the borderline arches with the brass wire help, but that was very obvious. Patient has severe crowding type. Crowding was there, but whether go for space supervision or for the serial extraction, you go for the segmental arch analysis and go with that. Patient is a horizontal grower. I have not shown you that lateral ceph or that can be FMA can be measured with the extraoral photograph also. So now the patient is treated by one of my students, Dr. Pranshu. And now it is getting treated. Everything is under control. Can it be done in maxilla? Sluice way. Dr. Ronald Bell has described sluice way creation in the mandibular only, but I have tried in the maxilla also. This has been done. The sluice way was increasing the arch perimeter by anteriorizing this central incisor. There is lack of space for this also. So sluice way, that is a lateral cutting, means incline cutting. Buccal measurement is not disturbed, only from lingual to buccal. So this will slide on this way, and this will come distally also. You see, it has started. It is started moving out. Now there is a to treat this. Once it comes anteriorly, there will be room for lateral incisor also. I forgot to insert the animation here. Sorry for that. Now that here is a sluice way created, and this also started moving, because first we got the room for central incisor by proclining the teeth, and here it is the things are solved now. And 2x4 itself is acting as a space maintainer. There is no need to give the palatal space maintainer. So this is 6 months. It is corrected by itself. So 85% of the cases with moderate crowding do have flush terminal plane. These cases have a tug of war for D space to be enclosed by anterior and the posterior segment for class 1 correction from posterior, and relieving of the crowding from the anterior. So these cases are often missed to assess a space condition despite being in large number. That if you start observing early crowding, the pattern of eruption, early incisor exchange, first transitional phase, only if you are start observing it, you can increase the number of patients by many folds. And please do not go for the space maintainer charges. It is a space supervision charges, which take a good amount of time, that is 2 and 2.5 years sometimes. Okay, so charge for your treatment, not for the space maintainers. Some of the severe crowding. So I have reserved the severe crowding for the long faces only. You might have heard only the cast analysis, that is mixed dentition analysis by cast only, but there are some cephalometric analysis. Nobody practices, but that is good. First is tweets analysis and the total space analysis by Merrifield. It is the severe condition where you see these type of the things. Okay. Here, many times this ideal situation is not done because of the severe crowding. The
Excuse me, ma'am.
Yes.
Hello.
Yes.
Ma'am, sorry to interrupt, ma'am. You will be continuing the lecture tomorrow also, ma'am. Will you?
Okay, just 5 minutes. Give me 5 minutes. I will. This is a last case only. Sorry
Okay.
for longer lecture. Actually,
No, ma'am. Actually, due to time constraints, ma'am, and we have we have given a time slot for tomorrow also. We have time slot for tomorrow also for your lecture for the continuation. So yes,
Chalo,
ma'am.
okay, I will end. I have discussed the borderline cases very nicely.
Yes,
Hope
ma'am.
you understand. So only the severe case is remaining. That is very short. So we will continue tomorrow. Thank you very much, everyone, for patient listening. Thank you. Bye.
Thank you for such a knowledgeable session, ma'am. Now,
Yes.
um,
I close. I should.
ma'am, tomorrow, ma'am will be continuing the session from 4 o'clock, ma'am.
Yeah, that would be better.
Ma'am, 4 in the evening, like 4 to 5:30.
Yeah, 4 to 5:30. What? How much time? I don't know how much time it will take. It always take long.
Oh, okay, ma'am, no problem, ma'am. So we'll inform the delegates, ma'am, about the timing, and we will create the Zoom link, ma'am, and we'll
Come with the caliper, with the download form, and some of the cast maxillomandibular.
yes, ma'am,
And
yes.
it would be good if it is a early transition phase. That means incisors are erupting.
Yes, ma'am. We have provided the PDF to all the delegates, ma'am. They have downloaded that. So we'll be continuing the session tomorrow.
And
And
hope everybody has downloaded the app, so that will be easy for me to make them understand.
yes, ma'am. And ma'am, we will be looking forward to continue the session tomorrow.
Okay.
Yeah, due to time constraints, ma'am had to
No
leave,
problem.
so she'll be
I was thinking that it would get longer.
yes, ma'am.
Sorry.
Okay,
Sorry.
so thank you,
Hope
thank you,
everybody not bored actually.
thank you so much, ma'am. So now we will proceed towards the end of today's session. The details of tomorrow's meeting will be sent to you in the group.
Yeah.
Yeah,
Okay. Thank
yeah.
you.
Thank you,
Bye.
everyone. Yeah.